This podcast is CME eligible. To learn more about CME, Alex, what do they do?
They can either go to the CME tab associated with this episode, or they can go to geripal.org/CME.
And on to the show. Welcome to the Jerry Pal Podcast. This is Eric Woodera.
This is Alex Smith.
And Alex, today we're going to be talking about elder mistreatment, prevention, and solutions. Who do we have on with us to talk about this topic?
We are delighted to welcome Julia Hiner, who is a geriatrician and fellowship director at the University of Texas Health Science Center in Houston. Julia, welcome to the Jerry Pal Podcast.
Thank you so much. I'm thrilled to be here.
And we're delighted to welcome Carrie Rubenstein, who is a geriatrician and fellowship director at Swedish in Seattle. Carrie, welcome to Jerry Pal.
Wonderful to be here. A long-time listener, first-time guest.
Wow, this is the first time, Carrie.
And Tony Rosen, emergency medicine doctor and researcher, and I know him from the Beeson meeting. He's at Weill Cornell and New York Presbyterian Hospital in New York City. Tony, welcome to Jerry Pal.
Thanks very much. Really appreciate the invitation. Excited to talk to you guys.
So we got a lot to talk about. We did do a podcast on elder mistreatment. Was it 6 years ago, Alex?
6 years.
With Laura Mosqueda.
Laura.
It's kind of an update where we are right now as far as prevention and solutions. But before we get into that topic, Tony, do you have a song request for Alex?
Yes, I'd like Alex, or we'd all like Alex, to play Eleanor Rigby.
Why did you choose this song?
Well, I mean, Eleanor Rigby is obviously an amazing song, one that we've all kind of known the words to since we were kids. And I think we all sing along. In fact, I think I've actually sung along with Alex on this song many times over the years. But it's a song about loneliness. It's a song about loneliness for older adults, with social isolation, and even perhaps sort of societal neglect and folks who go unnoticed. And I think we're hopefully going to discuss during the session, but there are a lot of opportunities that we can prevent elder mistreatment by increasing social connectedness and social services. So really excited to hear Eleanor Rigby.
Love that. Here's a snippet. Eleanor Rigby picks up the rice in a church where a wedding has been. Lives in a dream, waits at the window, wearing the face that she keeps in a jar by the door. Who is it for? All the lonely people. Where do they all come from? All the lonely people. Where do they all belong?
Wonderful. We'll have a little bit more of that song at the end of that podcast. Carrie, I'm going to start off with you. I initially called this Elder Abuse. That was the name of the podcast title. And you suggested something different, that we should be using elder mistreatment, prevention, and solution as our title. Why did you suggest that?
Eric, thanks for asking that question. Abuse is a scary word. I think words matter, and nobody wants to think about, engage, or even really talk about abuse. But in our field, mistreatment, prevention, solutions, this is a way to really focus on the opportunities, like Tony's already said, that we can bring to the table, that we can intervene, that we can creatively care for the most vulnerable people.
Yeah.
And people give you a funny look if you say you're into elder mistreatment. You got to couch it with some prevention and care for sure.
Well, let me ask you that, Julia, because when I think about, I thought it was elder mistreatment was both elder abuse and neglect. I'm pretty sure I actually had that in our podcast with Laura Mosqueda. Is that no longer the words that we should be using, or is it something different?
I think the words that are in vogue kind of come and go. And, it depends on who you talk to. But I think what's ultimately most important is how we're reaching down from, the proverbial ivory tower to the people we're taking care of. What do our patients understand? What words are they using to describe their situation? And through that, we can come to this common understanding. But in my practice, I say elder mistreatment as an umbrella term.
Yeah. What do you do, Tony?
From my perspective, I feel like mistreatment describes the phenomenon that we're trying to focus on and combat. But I also recognize that we want to talk to people about what they understand the phenomenon to be. And so mistreatment, I think, better encompasses what we think we're trying to focus on preventing and finding solutions for. But I know that elder abuse is still a term that a lot of folks use, and
Yeah.
so we want to make sure that they know that that's still what we're talking about, is what has been called elder abuse and neglect.
Is it,
And for,
and then what is the phenomenon? So what's encapsulated underneath that umbrella?
Well, certainly in that umbrella, you've got all the types of abuses. You've got physical abuse, sexual abuse, emotional abuse. Some people call financial exploitation financial abuse, or break it off into its own category with scams and fraud. And then you've got the neglect category, whether it's by a caregiver or yourself, in both domains of physical, medical, and mental health. And then, of course, exploitation and everything that goes with it is under that elder mistreatment heading.
Yeah.
And from our perspective, again, and I don't want to give a definition, but I think it's probably also useful for us to hear the definition and make sure that we're talking about the same thing. I think the definition and that most of us think of and use is that elder mistreatment is defined as an intentional act or a failure to act that causes or creates the risk of harm to an older adult by a caregiver or another person who is trusted. And so, to pause for a second, those are all important ideas. It's not just action, it can also be inaction. And it's not just harm, it can also be risk of harm. And it's not, and it's not necessarily a 63-year-old walking down the street who gets his or her purse snatched. This is someone who is in a trusting relationship with the older adult. And that's the phenomenon that I think we're talking about, and that we want our colleagues to think about, and we want patients to understand and think about as well.
So, like, Nigerian prince scams would not fit under that definition?
They would fit under that definition if the person is vulnerable, is considered a vulnerable adult.
But it's not a trusted relationship, right?
You know, it's such a great question, Eric, and it is often debated, but I think most of us would say that these are confidence scams, and these are scams that are about developing a trusting relationship. In fact, the trust is at the core of the scam. And so while the Nigerian prince scam is not necessarily your son taking your money, it is unequivocally something where you are exposing an older adult who is at risk. And in fact, some folks will add that to the definition, that an older adult is specifically at increased risk because of their age or disability.
Well, what are the risk factors that we should, is there any other besides age that we should be thinking about when we think about who are the highest risks for elder mistreatment? I almost said abuse. Elder mistreatment.
I know, it's hard to not.
Cognitive impairments is, I think, what shows up most in our line of work. I do work in capacity assessments of those who've experienced elder mistreatment, and we're always getting back to that. And that gets to some of the prevalence rates. You know, in cognitively healthy people living in the community, we expect to see 1 in 10, give take, experiencing elder mistreatment. But you had some cognitive impairment, especially rising to the level of decisional incapacity, not being able to care for yourself or make those decisions. And it goes up to 1 in 2 potentially. So It's a huge risk factor.
1 in 2.
1 in 2. Half of people who have cognitive impairment such that they've lost decisional capacity may be experiencing elder mistreatment at any given time.
And there's a lot of reasons for that. There's a lot of reasons for that. Some of it has to do with the caregiver strains and expectations that we have in a community in a society where we don't support them enough. You know, some of it has to do with the older adult who is living with dementia and unable to report. And all of these things together really significantly increase the risk, as you've just heard.
Do we know at all about like where it falls in as far as financial neglect, physical, sexual abuse, verbal abuse, psychological abuse? Like, is there one that's the most common?
I don't know if there's one that's the most common, but certainly a codependent, dyadic, or caregiver-patient relationship increases the risk. If there's financial dependence of the caregiver on the person they're caring for, that increases the risk of financial exploitation, for example. Or a caregiver with multiple caregiving responsibilities, such as someone in a sandwich generation. They've got younger people and older people. That's a risk factor for neglect, for example.
And I think I would say that that I think what we found is that financial exploitation, psychological exploitation, and neglect are more common. In fact, substantially more common than physical abuse and sexual abuse. I think that what's also worth pointing out is that as an older adult becomes more dependent, what we're starting to find is that neglect becomes more common as care needs increase and as dementia worsens. And so I think that's another important thing for us to think about.
All right, I
Before
got a
we
question.
talk-
Go ahead, Alex.
Well, but and this may be jumping your outline, Eric, but before we talk about, should we screen for this, should we, et cetera, could I just hear from you briefly, each of you, about why you are interested in this issue? Often we ask this question up near the front. Would that be all right? All right, Carrie, could we start with you?
Absolutely. You're going to hear a theme here because we talked about this, me and my co-guests. Mentorship and influence. I think that for me, so Paige Ulrey is innovative leading expert in elder abuse prosecution in King County, Seattle. And she came and talked to my residents and fellows over 10 years ago now. And as I invited her to do that, she had done that in the past. And as she's leaving, she said, "Hey, Carrie, we need a geriatrician to be part of our King County elder abuse multidisciplinary team. Would you like to join?" And I said, "I'm no expert in this." And she said, "Yes, you are. Come join us." And so her mentorship and then Laura Mosqueda has been a mentor of mine throughout my entire career. These people have, helped me realize that planting that stake to be involved in this work helps me remember why I'm here to begin with.
And that is your focus on people who are extraordinarily vulnerable?
Yes, to be able to create, to work with teams to create and think about prevention, in the clinical setting and solutions when we're faced with these difficult situations is a privilege to be able to do that.
Julia, how about you?
So I think a lot of my career in geriatrics came back to serendipity of running into these amazing mentors at just the right time. And for me, I'll be honest, I really didn't have any interest in it throughout fellowship, but I walked into my role as brand new faculty. And as the new kid on the block, I had space in my clinical schedule. And they said, "Hey, we're going to stick you with some elder mistreatment work and see how you like it." And ended up being the best thing ever. And so I was honored to be mentored for a couple years by, the late, great Carmel Dyer and now, Laura Mosqueda, but also so many others in the field. I watch and listen to y'all's podcast and I was like, man, that's an important person. That's an important person. But mentorship and sometimes just being where you need to be to get that experience amounts for so much.
Yeah. And what is it about this specific issue, elder mistreatment, that draws you?
I really, at risk of sounding like a medical student interview, I care a lot about helping people when they are at their most vulnerable and when they feel like there's no way back up to the surface for air. And being able to talk to people at that really vulnerable period and meaningfully do something right then, over the next, couple months that changes their experience, gets them to be safer or to be, start the process of making them whole again. I find that really fulfilling. And I love the relational aspect of that as well.
Yeah. Thank you, Julia. And Tony, you're an emergency medicine doc, slightly different perspective than the geriatricians. What drew you to this elder mistreatment?
Yeah, I actually came to elder mistreatment at the very beginning of medical school. I arrived at medical school already interested. I'd come from public health and I was interested in older adults And I was also interested in intentional violence as a public health problem. And I happened to land at Cornell, where Mark Lax, who's been my mentor since the very beginning of medical school and is a friend of many of us on the podcast, he really introduced me to this community. And so I think that one thing that's probably worth reemphasizing is that as challenging of a topic as this is, the community that works on this and the community that's devoted their lives to this vulnerable population is an extraordinarily supportive, generous group of folks, and frankly, hopefully growing group of folks. And it's great. I mean, Laura Mosqueda has been a mentor to all of us, and it's really a special group to be a part of. And you feel like you're really having an impact, and you're really working with folks that are thinking about how to help people at a really challenging time. And I'm an ER doc, and in emergency medicine, what we're really trying to look for is people that might have a life-threatening thing that you can't see. It's obvious if you come in with a blood pressure of 50. But from my perspective, what we're supposed to be looking for is, hey, there's something life-threatening going on that might be subtle. See if you can identify it before they leave the emergency department. And I think that elder mistreatment is something that we can do a much better job of in all clinical settings. But of course, I'm particularly interested in the emergency department.
Well, let me ask you this. I love the line of things that you can't see. One is that you can look for things. Another is just general screening. But I do believe USPSTF came out with their recommendations maybe less than a year ago that follow up previous recommendations that there just isn't enough evidence to recommend routine.
It doesn't say don't screen.
It's just there's no evidence. No evidence for the screening tests, no evidence that there are like solution. Like there's just not enough evidence in this field. What's your take on that?
I think there's a bit of a disconnect from the clinical reality of what people and what, physicians and other healthcare providers are seeing versus, maybe what the evidence, hasn't quite caught up to seeing. I think anyone who does this work, who takes care of older adults, is certainly seeing that these are vulnerable people who benefit from the screenings and the observations and the interventions. But, I will say, seeing the U.S. Preventive Services Task Force say that, it was a great kick in the butt to start doing some research to change their minds. And I've seen that in my colleagues and myself, that we all were kind of like, okay, you want evidence? We're coming.
That's great. I love it. Go ahead, Tony.
No, I was just going to say, I agree. Many of us here, we're all working on projects to try to help fill those gaps. So perhaps you'll invite us or other colleagues back in a couple of years and we'll have more to say. But I think that's really, really an important thing, is to say we can do better. We can find better ways both to improve screening processes, but also, and I think another really important thing is, as clinicians, we're much more enthusiastic about screening for things when we really feel like they're excellent solutions. And so from my perspective, I think we also want to work on solutions so our clinical colleagues can say, of course I want to screen for this. If I find it, I got this great opportunity to help this older adult and this family.
Do any of you currently would recommend screening for, like, aside from USPSTF says, for primary care providers to screen for elder abuse?
I certainly think it's important. And I think we're starting to see a shifting trend. Centers for Medicare and Medicaid Services came out with their new recommendations for screening in vulnerable adults. And kind of one of the sub areas is looking in an age-friendly system, starting to mandate it. So I think the tides are shifting, but in primary care, that's where the longitudinal relationship is. They can see those subtle changes. They have that trusting relationship to open up and help their patients. They know the resources in their community.
And Tony, you had an article in JAGS about this recently, finding, I think, just to summarize a long and complex study, that people who had experienced elder mistreatment were no less likely to see their primary care physician than people who hadn't. Do you want to expand on that?
Yeah. The first thing I'll say is that one of the reasons we did that is we had found that people are more likely to see the ER in the hospital. We thought, oh, that makes sense. They're more likely to get shuffled into that part of the system. And so we maybe thought, well, maybe that means they're less likely to see the primary care provider. And we were wrong. we were wrong. In fact, they are just as likely, in some cases, immediately afterwards, are particularly likely to see primary care. And so it really emphasizes the big opportunity that primary care providers have to identify this. And again, just as Julia was saying, like most of my patients I've never met before. Whereas these are folks that you've seen longitudinally and you can identify, hey, this looks a little bit different. Things suddenly, they're not filling their meds quite the same way. They've missed a couple appointments. They're not quite looking the same way. The caregiver isn't behaving in a way that I remember him behaving last time. Those are the kind of longitudinal things that primary care folks have access to. And so from our perspective, we thought it was in some ways good that we were wrong because it identifies this opportunity for primary care providers to identify this.
And this is our specialty. We are pattern recognition specialists. We know normal aging and we know abnormal aging. And when you see, for instance, bruising showing up in the inner thighs or somewhere where you would not expect it, we need to be thinking about this. We're good at this. We can notice these changes, especially when we have the privilege of having these relationships over time.
But it's harder though, like than in peds, because there's some things like bruising. Again, probably in particular areas you'd be worried more, but bruising is actually really common in older adults too. Missing medications, and I think that is one of the issues with a lot of these screening tests is the specificity of it isn't very good. Tony, you're going to disagree. I see you shaking your head.
No, actually, I couldn't agree more, Eric. I was going to say that we have a mentor who's since retired who said elder abuse, it's not rocket science, it's way harder. And I think that's true. We care for kids in emergency medicine, and identifying bruising patterns that are unusual in kids is much, much easier. And identifying things that are out of the ordinary in kids is much easier. And by the way, there's a much larger evidence base to support any conclusion that you have. And so what I think that means for us is that it isn't necessarily only about screening. For primary care providers, it's about keeping this on the differential. It's about thinking about this when you're seeing patients and using that kind of spidey sense that we all develop. Things aren't quite adding up here. Why aren't they adding up? Is there something that I should be that I should be thinking about?
Carrie, would you agree? Kind of, it's more about kind of the spidey sense, keeping a differential, or
yes, and I think this comes back to really making sure that it's a training piece. We need, again, people think about elder abuse as this severe, this severe experience, a severe outcome, and therefore they're not keeping it high in the differential when things are more subtle. If we train people well to identify these subtle changes, to keep this on the differential, to consider this, and then to think about how do we use our teams early on when we start seeing some of these concerning, potentially harmful things happening, that's the opportunity.
I would add, though, that from my perspective, back to your question of screening, if your listeners do go back to listen to the June 12th, 2020 episode from Laura Mosqueda, who's amazing, and it was a great episode, she talks about 3 questions. And I think it might be worth re-emphasizing that you have an opportunity in primary care to say, has anyone close to you harmed you? Has anyone close to you failed to give you the care that you need? Has anyone tried to force you to sign papers or use money against your will? Thinking about those 3 questions, and Laura, who's, as I said, a leader and a mentor for all of us, she says that those are questions that I ask my patients, and that's one way to think of primary care screening.
Her ears are burning with all of her name dropping.
Yeah, I love that. I love that. Thanks for the callback to our prior episode too. Okay, then what? So I think you also mentioned, in part, we worry about screening when we feel like there's nothing we can do. Aside from calling APS, What are other solutions?
That is a tricky wicket. And one thing that I find in when I'm going around, various parts of even just the state of Texas, because we're demographically incredibly diverse here. I'll come in, from my Houston perspective, coming from the world's biggest medical center and say, oh, there's this resource and that resource. And then I get these smaller town folks and going, that's fantastic. I don't have any of those things. So that's a really hard question, but I think there's a lot of opportunities surrounding caregivers and support in caregivers and building that up. I don't know if those resources are as strong as they need to be. In fact, I'm going to argue that they're not. But how we support our caregivers is hugely impactful for the care that they can give. And colleagues of mine work on interventions to support caregivers to drive down elder mistreatment risk, but also actual elder mistreatment in practice.
So it's going back to what you said earlier, that dyadic relationship, the caregiver, the older adult. And instead of waiting for the elder abuse to happen, what supports do we have for that caregiver to try to prevent that at-risk relationship turning into?
That's in the office setting, but also in the policy setting. What are we doing for considering paid caregiving, right? What are the opportunities to make sure that this is not only that, but training our caregivers, meaning the workforce, and valuing the workforce of paid caregivers so that there's an opportunity to support family members when they're going through something like this.
We like to say that interventions that support caregivers and support families are elder mistreatment prevention. You may not be calling them that, but they really are elder mistreatment prevention.
Do we have any evidence for that? Is there any studies looking at something focused on caregivers that decreases elder abuse risk?
It's a great question. And the answer is hopefully coming, but nothing yet that confirms that from an evidence perspective that I'm aware of, at least.
Zach Gasumis had been working on some interventions with caregivers. I believe it's called Kinder. And I don't remember all the details of it, but essentially the outcome was that they were able to bring down elder mistreatment, I believe in the caregiver support intervention group, down to 0. And it was probably a pretty small study. I don't want to say anything out of turn without having it in front of me, but I think it's coming. I think we're going to find more and more of this work, and keep out an eye in the nursing literature too. I think there's a lot of work coming from nursing too.
And then
that's a great point. I should probably cut myself out because that's absolutely right. And it's not carrying. I'll come up with the study in a minute, but that's absolutely right.
Well, let me ask you this, Tony, because you have another thing that I've been reading about in JAGS called Vulnerable Elder Protection Team, or VEPT. What's that?
So for us, I'm an ER guy, and we're used to child protection teams. And the reason a child protection team exists is that the ER doctor and the hospitalist are busy with the heart attacks and strokes. And when a patient comes in that might be a victim of child abuse, people are like, well, I don't know that I know what 5 phone calls I need to make and what I need to do next. And in our experience, there are about 1,000 or more than 1,000 child protection teams that are hospital-based in the country, and we knew of no elder protection teams. And so that's what we thought we'd create. Something that was ER and hospital-based, a consultation service. And what we were hoping was that if you create a consultation service, you're going to cause 2 things. One is that your colleagues in the ER and hospital are going to be more likely to recognize this. And 2, that when they recognize it, it's going to be less work for them. And that's what we found. We weren't sure. We sort of set it up saying, well, worth seeing. Maybe people will call us, maybe people won't call us, but we get called a lot. And it feels like we're getting called more and more as more folks around our health system get to know what it is that we're doing, and also that folks outside our health system get to know what we're doing. But I want to add a couple of quick things about the program. The first is that we set it up as sort of a physician-led program. We thought we were going to be physician consultants. And then we added social workers and found that they're way more important than us. And they're really the heart of our program. And I think that what we're trying to think about is, can we consult inside the hospital? Can we support folks in a hospital setting? In other words, unfortunately, I'm a reactive doc. I'm the doc when things go badly. You end up in the ER and then you end up in the hospital. And so we'd love to talk more about prevention. But in our world, we also want to be able to support inside the hospital clinicians that might see stuff but might not know what to do next. And so we've really felt like it's been an impactful program, and it's one that we're excited about. And we've got colleagues in Colorado that have just developed a sort of a program that's similar to ours, probably even better than ours. And we're thinking about ways to expand this model.
And who's on the interprofessional team right now?
We have in our program, we have ER clinicians who see the patient initially. We have social workers, and then we have a geriatrician. But interestingly, we also have buy-in from folks, everyone from security to legal to patient services. It turns out that there are a lot of issues around elder mistreatment, issues as different as, well, what if the healthcare proxy is the abuser? There are all kinds of things that are useful to build a team around and to think about, well, maybe ethics should be involved in this case. How can we support this family? And once we discharge this patient, is there a way for us to support them once they return to the community?
Yeah. Carrie, what kind of team do you have up in Seattle at Swedish, or if any?
Yeah, so there's a lot of similarities. So I participate in this elder abuse multidisciplinary team that is out of King County, and it is a group of diverse and brilliant professionals. Geriatrics is the medical specialist involved, but we have APS, and so APS brings its most difficult cases. We have Aging and Disability Services, which is sort of our AAA center. We have specialists, police representatives, law enforcement, attorneys. Paige Ulrey is the co-founder of our MDT. We have financial specialists that are specialists in looking at people's bank accounts when there are concerns for exploitation. And, again, this is a opportunity that potentially, if enough people in the community know about it, it can increase their likelihood of reporting. Because what happens with this team is the cases get brought to these people as we come together, and my trainees, my geriatric medicine fellows, are part of this team too, which is a fabulous experience, important experience. And we can come up with creative solutions that nobody would ever thought of alone, and bring that back. We bring in to this core team, we bring in the PCP sometimes. We bring in the case manager from their community. We bring in sometimes a community service officer that noticed something in the neighborhood and brings it to us. So this is a tremendous opportunity to come up with creative solutions that could prevent things from getting worse.
And Julie in Houston, do you have anything similar to that?
Yeah, so I'm lucky to get to participate in more meetings than I want, but kind of three multidisciplinary teams really composed of very similar people as Carrie described sitting at her table. But I work, probably the unique one that I'll highlight is an elder abuse fatality review team, which partners with our medical examiners in Houston. And we receive referrals on situations that elder mistreatment might have resulted in someone's death. And we are able to look at it from the ground level on up and look to see if there's systemic changes that we can implement with, getting personal care homes and boarding homes licensed and monitored with the same rigor that, facilities are supposed to be. Were there opportunities for, emergency medical services personnel who are boots on ground in these homes to make APS reports? And just looking at all these opportunities and seeing what policy change can be enacted from that. But in addition to that, I do run-of-the-mill, elder justice, multidisciplinary teams. Again, very similar to what Carrie is describing. It's actually one of the first things I think we bonded over.
And then I guess my question is, how much is it important to have these multidisciplinary teams versus that we have APS involved? Like, isn't also this the point of APS, or is this in conjunction with APS? Like, how does that all fit in?
I would love the opportunity to talk about APS because I think this came up on your last
go ahead.
podcast on this topic. I think a lot of clinicians feel like APS is a black box.
Yep.
Where you send your concerning situations in and you get nothing back. And I really want people to understand that APS is not an emergency response system. So if you're in an emergency, don't call APS. But APS, think of it as a safety net, right? And I've worked a lot with APS on these teams. I know Julia has as well. Tony, you've had a lot of communication, I'm sure, with APS. Guess what? They want to hear from us. They want to talk to us. They want to collaborate on your concerns, but they just assume, and this is no joke, they assume you don't have the time. And so for every situation where you make an APS report, and I encourage you to learn your state's and your community's ways to report, consider tracking down the APS investigator and communicating with them, because I think that is a way to allow APS to do what it does best, which is investigate and then bring resources that an individual might need. These teams, these, multidisciplinary interprofessional teams that Julia and I are just talking about, they are for the toughest cases when it really hasn't made progress through APS, because you're bringing in even more folks they're expert in this area to come up with solutions.
Oh, well, how about for you, Tony? How does APS fit into the VEPT team?
It's a great question. For us, a close connection to APS is a really important part of our program. We connect with them when we see a patient. We're able to find out from them whether they have active information, whether they have concerns, and we work with them to make sure that once we're ready to discharge a patient, that we're handing off warmly to them in the community. And so I think that one of the things that's really important is the closer a relationship and the stronger a relationship you have with APS, the more confident you can be that the services that they're going to help provide and the work that they're going to do is going to support your patient.
And I think the corollary to that is when APS gets to know, the physicians in their community and knows, who's out there ready to talk to them, it makes APS more and more comfortable to reach out to us with these questions, with these opportunities to engage and help, the patients, the clients that we're all taking care of. So it's a two-way street.
Limitations. There are limitations. I heard recently an APS investigator said they had 40 new cases. The resources probably need more resources with APS. And then, APS can't force folks to accept help. And so
that change, do you think that APS should be given the ability to force folks to change? Or is that too much of an infringement?
You mean to accept their help?
Yes, right.
I'll go ahead and say no. I think the preservation of autonomy, even to make, what I think maybe people would collectively call a bad decision, is just kind of one of those fundamental rights of, being an adult and growing up. Now, does it mean you get individuals showing up with APS recidivistically? Absolutely. And that is, I think, a big discomfort for people, especially those who don't work explicitly in the elder mistreatment care and prevention space. I think that's a big area of discomfort. And, every kind of niche, every field has a point that hurts. But I think we have to preserve autonomy as long as they have the capacity to refuse and understand. Yeah. I think we have to do it. Even
I'll push back a little bit about this and say that for example, so Brendan Saliner's a Greenwall scholar. He's a PhD professor out east, and he's really interested in what do we do with people who are recidivistic, particularly around substance use. and that there is a role at some point, he's come to believe, for law enforcement stepping in and enforced treatment. And I wonder if that's like a leading edge, and that we may get to a similar place in elder mistreatment.
I was going to say it's a really good question. I think to some degree, ultimately, self-neglect becomes a real ethical dilemma. We allow our patients, our citizens, our fellow citizens, ourselves, to make really risky decisions. The dignity of risk is at the core of how we see the human condition. However, there becomes a time when folks can no longer make safe decisions, and also there is folks that live in apartments. And if you live in an apartment and you're leaving the stove on, you might not just be endangering yourself, you might be endangering folks that are above or below you. And so I think that, Alex, it's a really provocative and thoughtful question. And I think that we are continuing to try to figure out how we can best serve these patients and families. And we're continuing to try to figure out about how we can prepare for crises in older adults who may be not making great decisions.
I remember going around 20 years ago in my fellowship in geriatrics. I went around with APS, and we would be visiting people in apartments. And the one thing that always stuck in my mind is I also learned that, at least in San Francisco, sometimes the people who call APS are the landlords, and not necessarily for good reasons. It's that rent-controlled apartment. Yeah. So it is this really big challenge. Speaking about fellowships, Julia, do you have a fellowship in this too?
Absolutely. No, I am so thrilled you asked about that. So as of January, we got approval from the Texas Medical Board to officially start and create our fellowship, which is Elder Capacity Assessment and Mistreatment, or ECAM, as I like to call it. And that sprung from our fellow rotation, which I've been spearheading for, I guess, the last 8 years now. And yeah, no, it is a full year of training, working with all these partners, all the people in our multidisciplinary teams to learn their sides of the job, and more on that. Yeah.
Who's it for? Physicians, NPs, social workers?
It is. For simplicity reasons, it's currently limited to physicians with our preferences for people with backgrounds, of course, in geriatrics.
Yeah.
That's our top choice. But also internal medicine, family medicine, neurology, psychiatry, and of course, couldn't forget you, Tony, emergency medicine too.
Is there a website for it?
Yes.
We will have a link to that on our show notes. So
Wonderful.
I am going to just real quick, last minute. This is lightning round. If you had a magic wand, you can change one thing that practicing clinicians could do around elder abuse. What would you use that magic wand on? Tony?
I want clinicians to be thinking about this. I want clinicians to be, when they're engaging with patients, thinking, is this something that could be contributing to why the patient is in front of me, and what's changed since I last saw them?
I love it. It's like shortness of breath. You always kind of think about PE, like should be in the back of your head. Julia?
I want mistreatment to be another M in the 4 or 5 M's framework, because I want it to roll off the tongue as easily as mobility, medication, mentation, what matters most. Because when we do that, it's at the front of people's minds and they're thinking about it. It's always on the differential. So I want that education to back it up.
Adding another M. Love it, Carrie.
And leveraging the training. I want every medical student resident in the country to know that choosing geriatrics means understanding that elder mistreatment is a social justice issue, and this is where you can have an incredible impact.
I love that too. I'm going to add I think 7th M, music. Alex, do you want to do a little 7th M?
Father McKenzie, writing the words of the sermon that no one will hear. No one comes near, looking him working, darning his socks in the night when there's nobody there. What does he care? All the lonely people, where do they all come from? All the lonely people, where do they all belong?
Julia, Carrie, Tony, thank you for joining us on this podcast.
Thank you.
Thanks for having us.
Thank you so much.
All of our listeners, thank you for your continued support. We'd also like to do a special shout out to all of those supporters who've donated more than $250, including
Brian Castle, Victoria Brand, Susan and John McFadden, Christopher Heck, Emise Samoji, Matt Schuster, Carrie Hagan, Lloyd Woolstat, Kari Levy, Marnie Fetzer, Ron Sabar, Stephanie Gabatuller, Patrick Lally, Richard Lewis, Margaret Young, Cindy Harris in honor of Emily Guillot, April Sear, Anna Naik, Xinyi Wang, Sudha Chandrasekhar, Michael Reisner, Asher Edwards, Susan Nelson, Rebecca Goldstein, Rochelle Bernacki, Carol Dietrich, Mark Andrews Wren, Elizabeth Cobbs, Amy Rack, Meg Walhagen, Xinyi Wang, Sharon Bragman, James Tulsky, and Yana Scharf, Kelly Strait, Michael Bordowski, Jessica McFarlane, Gretchen Schwarzy and Joshua Mesrich, Rob Razak, Diane Meyer and Sean Morrison, Elizabeth Chung, John A. Hartford Foundation, and Harry Hahn.
Thank you very much for your continued support over the last year. Your support keeps these lights on.